Live.
Okay, welcome to Samsung Medical Center. We are waiting. We started too early. Okay, this is Hyeon-Cheol Gwon from Samsung Medical Center. This is Song Young-bin, my dear colleagues, and Dr. Jumyoung Lee, and my dear fellow. I cannot hear. 안 들려. Actually, you can hear me. Okay. Like Dr. Song to explain about the current today's case. Dr. Song, please.
Next slide, please. Okay,
촉이 안
54-year-old male presented with exertional chest pain,
접촉이 안
CCS class 2, and for 2 years. Echocardiography showed that normal systolic function without regional wall motion of
좀
abnormality.
체크해라 이렇게 들렸다 안 들렸다.
He has no specific medical history. Next, please. Electrocardiography showed that normal sinus rhythm without significant SG change. Next.
클렉스를 꽉 눌러봐.
Okay. Baseline angiography showed that the anomalous origin of right coronary artery, and there is some chronic total occlusion at proximal site. Okay, next, please.
이게 들리는 게 들렸다 안 들렸다.
Left coronary angiography showed that there are some plaque on mid-chair AD, but there is no significant stenosis, and there are some multiple collateral to right coronary artery.
Okay, this is the current total occlusion in the proximal segment of RCA of anomalous origin. The issues are integrated approach versus retrograde, optimal guiding catheter for right coronary, and selection of collateral retrograde approach, and selection of externalization technique. Okay, what do you think? So should I start antegradely or retrogradely first?
We don't have any sufficient information regarding the collaterals from left to right.
Yeah, I'll show you today's angiography. Okay, angio please. Angio please. Okay, this is the angio today. We tried to selective angiography using the extensive catheter, but so injection is too strong. We can see both right coronary and left coronary. This is XB EBU 4.0 6 French guiding catheter from the left, and Godzilla 5 French extension catheter. So you can see collateral in left side. The circumflex collateral is very tortuous. Can you see that, right? Next. Okay, collateral is going up and down to the PL branch. Next, let's look at the left side collateral. First septal, there is no connection. Second septal, I'm not sure. Third collateral, just above the LED angle, there is some connections, but didn't fill the epicardial artery of right coronary. And the epicardial collateral, you can see at the distal LED, epicardial very tortuous. Next. Maybe this collateral going to RV branch. So now,
can we see the previous angio minus, minus, minus?
yeah, DDD, up, 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 up.
Okay,
Yeah, next.
yeah, +1, yeah. Can you see the origin of ipsilateral collaterals
From circumflex,
to the PL branch?
yeah,
Not the circumflex. There is a kind of long vessels that
yeah, this
goes
is coming
down.
from circumflex.
Really?
Above. That's atrial circumflex, I think.
Atrial?
Yeah, next.
So,
Previous.
so you don't have to zoom because we cannot see all the picture. Sometimes some people
yeah.
use a zoom angio, but We don't need zoom.
So the collateral you mentioned is the going upper side to
Okay,
atrial
okay.
side. This is atrial circumflex.
That looks great.
Really?
Although the angle at the insertion is not good, but it looks the largest collaterals.
It's quite a long way, and even we are
Yeah.
using the 9 centimeter guiding catheter. I'm not sure we can get there.
Is there a comment from the
Have you
panelists?
have you used that collateral before?
Of course, but
Wow.
it looks too long. It looks too long.
You
Yeah.
need a
You're an
90
expert.
centimeter guiding. And it looks like there are several collaterals to left side, system to right. And I think the third septal, even though the dye is not filling to the RCA, I'm sure that collateral is connected. But
Right.
and the question is
Next.
to do antegrade or using retrograde.
Right. So collateral, maybe third septal branch can be used for collateral, but if you can see here, next, it's quite tortuous actually. Quite tortuous. Size is okay, but quite tortuous. And epicardial collateral from the distal LAD also very tortuous. So nobody prefers integrated approach.
But we cannot exactly see the antegrade angiography.
Okay, next. Next. Okay, we start with the XB 3.0. XB left 3.0. This is actually my favorite guiding catheter for RCA-CTO, but nobody in my catalog is using that. Anyway, so as you know, hard tip of 35,000 wire is inside of it to control the curvature of the guiding catheter. Next, it's very anteriorly originating. The most frequent anomalous origin of the RCA. But I tried the run-through wire. Next. Yeah, this is the angio. I inserted wire to fix the guiding catheter, but it is not so successful. So this guiding catheter, the angle is too steep, going upward. And as you know, the anterior anomalous origin RCA is going downward. So this was a not good guiding catheter. Next.
Implants would be better.
Right, yeah. Next. Okay, I changed to implants. Next. So it's much easier to cannulate RCA. Next. So I tried to secure the guiding catheter with wire. Next. So actually, even if the AL1 guiding catheter is useful for the angiography, but the backup support may be poor. So I try to use the extension catheter for the secure angiography and backup support. I use the 5 French guideliner for the purpose. This is bilateral angiography. Next. This is another bilateral angiography. You can see the total segment in the proximal to mid, and distally in the cardiac angle, you can see maybe a tight stenosis there. Previous. Okay, what do you think? Integrate? You can try integrate.
In the minus angio,
Previous.
wire is in the side branch.
Yeah, maybe side branch. Down. Okay. Actually, wire was in the side branch, a very small side branch at the proximal end of RC, but it does not go through. I'm
This
not that lucky.
Are there a side branch at the proximal stump?
A small side branch, and there's several side branches there, very small.
Because of the poor backup from the right side, I think to shorten the procedure time, you can start retrograde first.
Everybody agree?
How about the opinions from the panels?
I also recommend a retrograde approach first because the lesion is length more than 20, and some tortuous. It looks some tortuous. So Dr. Kwon used only 5 French child
Guideliner?
catheter.
Guideline.
So guideliner.
Yeah.
So how about using the 7 French guideliner?
Yeah, maybe.
It's more
yeah.
useful
I can hear.
for the micro catheter and a double lumen catheter.
Right. So actually, we prepared the 7 French sheaths for the purpose, but I think 7 French is to me is too dangerous. There is a lot of complications. So I started with 6 French guiding catheter, but if needed, we changed to 7 French guiding catheter. And your point is correct, because we try the Corsair catheter inside of 5 French guideliner. It doesn't go in. I didn't know that. But 6 French, I tried the 6 French Godzilla inside the right coronary, but Godzilla doesn't go in. It doesn't go in because there is the angle. Alignment is not good, and the wire support is very short, very poor. It's very difficult to insert the 6 French. So,
But in this image, the antegrade microcatheter is already in the side branch, right?
oh no. Godzilla here.
I think there is some marker of microcatheter.
There is no microcatheter at this time.
Okay.
This Godzilla,
Yeah.
just
but wire is
run
already
through wire.
Long side branch.
Yeah, run through
Okay.
wire.
Just proceed, please.
Okay, actually, we thought that retrograde approach is the correct way, but we think we have to wait for a long time, and we just try antegrade for 5 to 10 minutes. Next. So AL1, 6 French guiding catheter, and the Corsair without extension guiding. Then use the ultimate UB3 wire, the wire you don't like. Actually, our plan is to use the UB3. Then we have a very nice wire of Asahi Gaia second. Next. So my user practice is to start with the UB3, and if it's not successful, within 5 minutes, I change to Gaia next second. Then if it's unsuccessful, go to Gaia third or Conquest. That's my strategy. So maybe you can discuss about the selection of wire here.
But if you use the stiff wire, the guiding catheter backup is important.
Yeah.
Even though the hard stiff wire we use, the wire back because of the
Right.
no good backup support.
Right. Actually, guiding backup was poor because of the alignment. Right angle alignment.
Also, yeah.
But fortunately, there is no calcification noted around through the coronary artery. So this is a good thing about that.
So Microcatheter got into the CTO region? Not?
Not yet.
Even though there are two side branches at just proximal stump, the final shot may show the UB3 and the kind of true proximal CTO segment.
How about the anchoring?
Anchoring.
No
This-
anchoring.
Small
Anchoring.
but side branch.
Yeah.
Side branch. So the fixed guiding
Yeah,
catheter
yeah.
much better.
Yeah, much better. So we have to use a 7 French guided catheter for that, right?
And this is the 6 French guiding catheter.
This is 6
See?
French. Yeah.
Oh, okay.
Yeah, I agree that for the integrated approach, you need an anchor balloon
Right.
to stabilize the backup.
So I'd like to apologize that there is a progress of the procedure. So this is like a video demonstration. So
I think so.
My plan was try integrate 5 or 10 minutes, and the video is on. We discuss and try the retrograde approach. That was my plan. But next, it looks like a video demo. Okay. Fortunately, the UB3 wire catch the proximal segment. Okay, next. The backup was very poor. And
What is the wire?
UB3.
UB3. Yeah.
UB3. Actually, UB3 is my favorite wire because it does not go away. It does go outside the vessel. You can feel the tactile feedback. And Dr. Lee, you like that, right?
Yeah, that is also my favorite CTO wire.
When Dr. Lee, Jumeng Lee, came to my hospital many years ago, I taught him about using the UB3, and he really liked that because in most of the CTO case, UB3 is quite successful. So how about in Japan? So what's the popularity of UB3 wire in Japan, Dr. Otsuji?
Oh, yes. In this kind of the region, if we don't want to
One-to-one talk.
guide wire outside, we usually use the UB3 first.
Do you like start with Gaia next second? Do you prefer Gaia next second for
No.
this case? Or you start with the UB3?
No. In this case, the backup is very weak, and if we use the Gaia, we cannot control the Gaia.
Oh.
So in this case, the UB3 is your choice is, I think, the best way so far.
Oh, I love that. Dr. Hyos Kim, every time he told me that you are very poor at selection of the guide wire, so
Yeah,
I was depressed.
wrong. And in this specific case, proximal stump has two side branches. In this time, when you use Gaia, free band Gaia, it is really difficult. Because I think UB3, you can manipulate the bending angle and penetrate in the center without side branches. Good choice.
Yeah, thank you very much. I'm so relieved. So the one thing good about UB3 is I can talk and as many talks as I can. That, as you know, in the previous version of Gaia second, there is some trouble of wire untwining of Gaia. The next is better. Gaia next is better, but previously the wire is damaged during the rotating the wire. So, but UB3, I never experienced that. So, next. So you went through. Surprisingly, it was my intention. We are surprised, and in just 3 minutes.
2 minutes.
No, not that fast. Make it 5. So, and next. Now I push the Corsair next, and it crossing next. So this is the very tight lesion in the cardiac angle. You can see the backup support is really poor. But when wire is inside enough, we can control the guiding catheter and have a better alignment. When wires in the proximal, you lose the guiding catheter when you control the alignment, but at this time, it's much easier for that. So next. So wire was inserted. The pushing the Corsair is quite difficult because of a poor backup. So
in this situation, we should care about the guiding because sometimes all would go out,
yeah,
even though the
right.
wire passes.
Yeah, yeah. Don't push too hard. Yeah, very, very, very important advice, I think. So there's difficulties in the progress of Corsair.
You use Corsair XS now?
Yeah, now
Yes.
access-
Undegraded?
Corsair X. Right.
Oh,
X.
in Japan, Corsair XS only the retrograde
Really?
because the pushability and driving force is Corsair XS is better than Corsair Pro.
Oh.
Corsair Pro. Corsair Pro
Corsair
is
Pro
better than Corsair
XS.
XS.
This is Corsair Pro
Corsair
XS.
XS, Corsair Pro XS, we usually use only
Retrograde.
retrograde,
Oh, really?
not undergrade.
Oh.
Because the profile of distal shaft, access is 2.1 French, while 2.6 French in Corsair Pro. There's some difference in the shaft thickness. Thus,
Okay.
in pushability, Pro would be better than access.
Okay. So.
So we usually use Corsair Pro in this case, not Corsair Pro
Right.
XS.
Yeah, yeah, you're right. I learned that. So,
Dr. Nass also has same opinion?
but
Yes, Corsair Pro XS is shaft is very narrow, so the pushability is very poor. So this case is okay, but some long and very hard region, that there is a discrepancy chip and shaft.
but I think the
So
backup support.
sometimes the chip is broken.
But I think backup support is poor. The low profile support catheter will be better, I think. Is that right?
Yes, this case is also, yes, I agree using the Corsair XS, but in the usual, especially in a very hard region, I don't recommend it to use.
How about the retrograde approach? So actually, I use a Caravel catheter for the retrograde. So the Corsair XS is better than Caravel.
I think so.
Yes, I think so. The tree's crossability is quite better compared
Yeah.
with the current.
Okay. That's why I'm doing the live demonstration because I'm learning a lot. Thank you, Barney, very much. Next.
Okay, which option did you take instead of microcatheter? Do you use balloon?
No. Just I pushed the wire further with aid of retrograde angiography. There was some resistance down there, so I angiography and pushed get the orientation and pushed wire. Then align the guiding catheter. There is no low risk of losing the guiding catheter at this time, and hold the guiding catheter. Dr. Lee hold the guiding catheter for me. So next. Yeah, and rotate Corsair. Rotate Corsair many times. Next. Yeah, finally, it was crossed. So not very hard lesion than I expected. So the issue I like to show you today is that the removal of I exchanged the run-through wire at this time, and I pull back the Corsair to the guiding catheter, and the removing the wire. I usually use the Nanto technique. Nanto technique use the injector to pressurize or to 14 atmosphere very easily. Not very easily, remove the catheter. But Dr. Lee actually Dr. Lee and my technologist Lim, Seyoung Lim, is inventing a new balloon. He insisted that we have to show that. This is the trap balloon.
Sometimes
It's like a commercial.
You use nanto technique
Yeah.
in the UV3 in the
Yeah.
micro.
Right.
But sometimes UV3 go into the small branches.
Right.
The risk of perforation is
Right.
high than
Yeah.
the standard wire.
So we
So be
tested.
careful.
We tested a different pressure actually. 18, 16, 14, 12. We found that 14 is best. If you pressure 18, your wire go anywhere, and there is risk of perforation. Anyway, recently many CTO specialists use a trap balloon, right? But as you know, if you use a 2.5 balloon as a trap balloon, after ballooning, it is very difficult to reuse that balloon. We take out the new balloon, use as a trap balloon. I cannot use that because the lumen is compressed. So we need a very small profile trap balloon. But Dr. Lee and asked Janus to make this balloon. This looks like a usual balloon. Wire is up to here. You can see that? Up to here. And there is no hole inside. Actually, it's under development. There's a lot of things to be further developed. So this is the first time I use that. But maybe I can. So this is commercial from Samsung Medical Center. Okay. So
조금 더
어디까지 내려왔지?
카드가 조금 더 나와야 되는데 지금 뒤로. 예, 거의
So-
끝까지 들어가시면 돼요.
The problem is that it's very difficult to see the balloon. Yeah, inflate. 조금 밑으로 view. Inflation. 안 보여? Where is it? Deflate.
제대로 안 됐어요. 더 올리셔야 돼요.
잠깐 deflate. It's the first use and first demonstration. I'm sorry for that. So 어디 갔어? 셀라인 좀 주고. So actually, I've heard that the several inflation. Several trap balloon is under development in Japan. Is that right, Dr. Ochuji? Over there?
What?
밑으로?
Several
밑으로?
track balloon.
Trap balloon?
트랩이 잘 안 되는 것 같은데 지금 저.
Looks like it's ruptured already.
Ruptured already?
No.
No? Ruptured
Pressure is
already.
maintained.
그러니까
야.
프레셔가
어?
올려볼까요? 아니
No balloon there.
요거를 빼.
I'm very
Is
sorry.
track balloon produced from Abbott Vascular?
No, the genus.
Genus,
Yeah.
but the same word track balloon?
Yeah,
Miniature
we
track
didn't
was
named
brand name
it.
of Abbott
Named it
Vascular.
already. 문제는 이거 꺼내야 되는데. Actually, there is an accident. So balloon, tip of balloon is stayed inside of a guiding catheter when I remove the balloon. So
볼륨은 볼륨.
I can see that. So maybe it's pushed away. Very gentle angiography from the above. 위에서부터. Yeah, very gentle. 밑으로. There is filling defect there. 위에, 약간 위에. Okay, you can see the filling defect here, right?
Was catheter cut?
No?
No?
I'm not sure.
What are you doing?
Balloon itself is stayed inside the guiding catheter. After we remove the
This balloon catheter was cut.
cut.
Okay.
볼륨 떨어져.
그런가 봐요.
팁이 있는 거 아니야? Maybe it's on the tip.
그거 말고
저쪽 볼륨이
Maybe I think we need to remove all guiding catheter wire.
예.
And the rewiring may be not so difficult because already we inserted the corsair wire, corsair catheter. Do you agree? I'd like to remove the
balloon is on the guide wire.
I'm not sure. The previous, you can see some filling defect. Upper side is moving downward. Can you see that?
Okay. Not bubble.
예.
Yeah, it
And,
doesn't look like a bubble.
We know that the balloon is not on the wire. Balloon is
Oh,
outside
outside.
the
Outside,
guide
right.
wire, so you can
Yeah.
retrieve.
So I need to remove all the guiding catheter together.
No, no.
Just
Just
use
use
another
the-
trap.
Another triple and
No, I don't like to take a risk. They recommend another trap balloon, but it can
Oh, yeah,
push
yeah,
the
yeah.
balloon out of the guiding catheter. So
Is there some risk of balloon outside the guiding catheter?
So
So
balloon tip was
aspirate,
cut.
aspirate is better.
Yeah, no. I don't like to take more risk. Rewiring may be very easy. So
잠깐만.
let me, 팁을 잡아봐. 여기 좀
Why?
비춰줘 보세요.
이거 좀 잡아봐.
Why did you use uncertified balloon?
Sorry. Yeah,
끊어졌어.
this is the balloon.
Where is the cutting point? How long is the remaining catheter in the
Very
guiding
long.
catheter?
You
10
can-
cm?
10 centimeter.
Quite
10
long.
cm.
No.
So
Oh,
that's
안
the
보이겠다.
another adhesion area.
Yeah.
Dr. Gwon, you
Yeah.
have, once you have enough time,
Yeah.
but you have not enough time. Please hurry up.
Okay. How many minutes do I have?
About
그건 뭐,
20 minutes.
Okay.
03.
20 minutes. That's enough.
We believe in your expert
Yeah.
skill.
20 minutes is enough, I think.
Enough time.
Yeah.
Once again, engage, and
Yeah.
then your
yeah.
choice of wire.
Run through is okay, but
Yeah.
CNY is better.
Yeah,
Because already the
Si연 wire.
concept past the
Yeah,
region.
시연 하나 주세요.
So there are
Yeah.
some antegrade flow.
Right.
Yeah.
시원.
시원.
I think the microcatheter support is better than the bare wire.
Maybe I could try because there is I will have a more situation that I use a triple. I don't like to use it.
but I think Sion or Sion Black would be easily passed.
이게 리비스
Because
같은 느낌인데.
The track is already
시원이에요?
owned by
시원, 새로 나온
microcatheter.
새로 나온.
좀 뻣뻣한데?
It is very interesting case. The proximal stump anatomy is not favorable because of two fine side branch, but there is no calcification. He noticed it and just tried to probe
Talk.
the wire, and luckily the UB3 wire entered the center through
Okay.
CTO segment.
Tip formation is not so good.
Originally, his plan was retrograde approach because, and he used radial, transradial to the right system and the femoral to the left system. Femoral has a strong backup, so his first plan was to do a retrograde approach, but his just probing was really
Corsair
wonderful.
and run through. New wire 좀 줘봐요. Form, yeah. Wire first first
through
curve is too large
새 걸로 하나.
because I was in a hurry. So run through 새거.
뒤에서 넣을게.
Okay. 오디오가 들렸다 안 들렸단다.
I know personally Dr. Gwon well for more than
선생님 이거 좀 받아.
about 25 years. He's really early adapter in terms of phone, computer, but in terms of wire,
들리다 말다.
he's really far behind the period. He still use run through.
But
It's very interesting personality. characteristics.
I do the same for the person I work with.
코스로 뒤에 넣을까요?
응.
코스 줘. 코스. No, 앞을 줘. 아, 이게 들렸다.
We can see once again the not favorable proximal stump anatomy.
Okay.
The good thing was it is not hard. It was not hard.
Yeah. But sometimes to very hard lesion with calcification, the UV3 is not working. But many times, soft total occlusion, if we try very the tapered wire, there is a risk of going outside and compromise the procedure. So, test. Okay. Yeah. Area view. Area. Test. The area view is very useful to align the progress of the wire. Leo? So this is going Albi branch. No, I have a Corsair. I forgot that. So guiding more deeply. Okay. It will improve the talkability of the wire. Yeah. Okay. Oh, finally got here.
예, 2.5.
It could have been worse. So my usual NATO technique.
No.
Okay. 14 atmosphere.
맞아. 뭐래?
난또 하신대요.
난토. 돌려봐요. Okay. 14. Let's see. 14? 14. Very smoothly going out. See that? 14
10
is
years
best.
ago, in SNU hospital, we used that
balloon.
maneuver
1.5.
to retrieve the microcatheter with wire in situ. And Dr. Lee, at that time, was impressed and propagate our know-how to some medical center.
Really? We knew that.
Yeah, inflate is very useful.
I learned from Japanese doctors. I'm pretty sure. So I will be careful about the backup support.
2.5.
2.5 아니야?
2.5 맞아요.
1.5.
1.5.
Dr. Lee is not well trained in SNH.
I'm sorry. yeah. 1.5.
Ten minutes left.
Okay. The target is I'd like to show you IVUS before you are leaving. Okay, backup support is poor. Guiding 좀 잡아줘. Yeah, hold the guiding for me. The deep through wire, hold the guiding. Then I pushed it. Not very much. Inflate.
Okay. 10,
14.
14.
Deflate. Okay, 14.
14.
Deflate. 14. Deflate. And if crossing is not successful, I usually use a zero-fold balloon. Inflate. 14. Okay, deflate. And after ballooning, actually, balloon is shrinked by the flow from the both side of the coronary artery. So I use nitroglycerin to enlarge, restore the vessel size. Tested. I gave it nitro. Okay. Yes.
2.5.
Okay. 2.5.
In the previous slide, the history, the patient complained, experienced angina for 2 years.
This is
I
not
remember 2
actually,
years.
yeah, it was 2
2
years, but
the
it is not,
actual
yeah.
CTO segment is not calcified, not
Yeah.
so hard.
Yeah. So many times we don't know exactly when it starts.
Probably the anatomic course would be critical stenosis progress,
Yeah.
and then recently or not so
10,
long ago,
12.
it is totally occluded.
Yeah, maybe that's right. The flute. This is 2.5, 30 millimeter balloon. In the long lesion, I routinely use 30 millimeter balloon. Inflate. 14.
14.
Deflate. Okay. Let's measure, yeah. Sizing. Angio. Should. Okay, this is what I get. And I'll let go to IVUS. 당기지 말고. IVUS.
Dr. Won, I have one question.
Yeah.
Why didn't you check the CT?
CT.
Yeah.
Flush. Usually I don't check the CT, so I'm not sure about the utility of a CT. But Dr. Zhang
However,
doesn't
in
like
this
my
case, in this case, RCA origin is not usual.
RC origin is clear, anomalous origin
Anomalous
from the
origin.
anterior.
And poor backups of the so I think the CT is very, very critical in this case.
Pullback 1mm, 1mm. Yeah, pullback. IVUS on the screen, please. IVUS, okay.
Okay.
Yeah. Okay. The CT showed anomalous origin. Angio showed anomalous origin. What's the benefit of CT? If there is a lot of calcium, maybe volume 좀 주세요. volume 200 full drip. This is CT distal segment. Vessel size is important. This is more than 4. Maybe we need a 4, but in angiography, it looks too large. Of course, the wires inside the true lumen, this is more than 4. Inside of maybe positive remodeling in the CTO segment, so I don't go too large, almost 4.5 vessel size. Let's see the proximal segment, not that. Here, vessel size 4.5, lumen size 3. There's some dissection here. So AL1 guided catheter, I usually have some minor or major dissection. So it's, usually dissection is developed in the inferior side of coronary artery because it's aligning to inferior side. Anyway, I like to first selection of a stent maybe 3.5, okay? 3.5, 48. 48 is okay?
Yeah.
그전 엔지오 좀 보여주세요.
Previous balloon was 2.5.
2.5. Yeah, 4.0 is too large. And the vessel size is actually 4.0, 4.5. It's possibly remodeled. And approximately distal end actually vessel size 4.0, but the lumen 3.0. Start with 3.0. Is better.
For me, I'd like to repeat injection of intracoronary nitroglycerin and use a bigger balloon to increase the actual size, to increase the distal bed up to the
저거
actual size.
1.5 다음. 1.5 다음.
네.
1.5. 2.5 말고 1.5 다음 거. I try to locate the 없어? 그전?
아니.
distal lesion이 어디까지지? Collateral, maybe beneath the, yeah, to the angle. Yes, marginal for the 48. So maybe we can start with the 3.0 48 synergy stent, then post-dilate. Do you prefer angiogram again?
Yeah.
Angiography? Sure? No?
빠진 거.
Test? 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 Okay. Same size angio?
Yeah.
Sure? 3.0 48.
Yeah.
And we post-dilated.
Yeah.
Synergy?
3.0 48.
Do you like to treat the distal lesion? This is intermediate lesion.
Where is your target coverage, distal point?
Just the distal to the third RD branch.
Okay. Mid to distal junction.
Yeah. And if 48 is short, then I go up to 3.5 balloon and post-dilate with a stent balloon. I'm good. Very nicely. A little bit short test. 뽑았다가 test. Then I go in. It's clear target test. It's too deep, but I think it's okay. Inflation?
Inflation.
A little bit short. 10,
10,
12.
12.
Looks a little bit deeper than you indicate.
Actually, third. Deflation.
Inflation.
Just less than 20 seconds?
Yeah.
It's wrong. Of course, he planned to do post-ballooning.
Yeah.
Definitely did not reach
Yeah. 왜요?
3.0.
가슴 아프세요? 환자분
우리
좀 봐줘. Okay,
괜찮으세요?
how long do I have?
조금 아파요. 네. 괜찮아요.
'Good
3.0.
sign of expansion.
So actually, yeah, pain. I don't like to go up to the 16, 3.0. Test. Yeah, 16 is okay. The complaint of chest pain. This is a sign of a vessel expansion. So recently, the size of a stent doesn't matter to me, right? Because if you insert the 3.0, 3.5, the risk of restenosis is very
3.56.
small. At least the data shows that the stent thrombosis rate is higher with the small stent with small, long stent. But
Okay, Dr. Gwon,
Yeah.
you have just 1 minute.
1 minute.
Stent.
3.5 열려서
We can stop anytime if you like.
Okay. I really appreciate
스텐트
your
3.5 열려서
educational live demonstration.
Okay.
course.
Thank you very
It
much.
is not,
Yeah.
although it is not exciting,
Yeah.
but it is really educational.
Educational means exciting.
Yeah.
So I cannot hear.
3.5 열려서
Okay. Okay. Thank you very much for joining us
Okay.
our lab demonstration. It was
We have to close.
not our intention, but I hope you enjoyed. Bye.
Thank you.
Good job.
Thank you.
Congratulations.
오디오 좀 꺼주세요.